how bad did they injure that? You know, was it, remember when we go to our grading scale, you know, if it was a more mild to moderate type of an injury, you know, and you can get them to fix the problem before it becomes a major one, I would say that would be less likely. You know, if it's a more moderate to severe, yeah, even with treatment, there is always that positive. There could be a weakness there, but the more you can get in there with cross-friction massage, anything to take that tension off the tendon, because it's just like a rope that you keep pulling and pulling and pulling, and finally it just snaps. If you can get the tension off of there, they're less likely to rupture that Achilles. Remember, I talked about too, chiropractically speaking, most of the time, patients with an Achilles type of, they're going to either have tendonitis or a possible rupture. Usually there's going to be a leg length inequality on that side, a shorter leg on that side that's going to create more tension there. So that's also something to evaluate too. You know, if they do have that type of an issue, sometimes, you know, stuff to encourage the leg lengths to equal out, whether it be a lift or some sort of exercise or, you know, some therapy to help even out those leg lengths. So AP draw of the knee. What are we looking for?
Elasticity.
Which is more common, ACL or PCL? So with that, what you're going to do, like I said, it all depends on your preference too. You're going to get both thumbs in that eyes and the knees there. You can also sit on the ankle, you know, just to add or take out any movement of the lower limb. And you're just going to do just that. You're going to go anterior or posterior anterior and then anterior posterior. And you're going to feel to see if there's any give or any move. You know, whether it be that anterior to posterior, posterior to anterior motion. Again, I would check the unaffected side first, just to see what their normal is, what their normal ligamentous laxity or lack thereof is. You shouldn't feel any palpable give. Remember we talked about almost like it's like a taffy stretching, and you're going to feel your thumbs coming up and clunking back down again. You're going to feel that movement if there is a pretty moderate tear of the ACL or the PCL. Remember we talked about too, with an ACL tear, especially with like a rupture, they're going to have immediate swelling. Remember we talked about that, usually the swelling stages. ACL is usually going to have immediate pain, immediate swelling. Those patients are going to, you know, feel an extreme pop or a pull in that ACL that's going to take them down. It's going to immediately swell up within the first couple hours. It's not going to be the type of knee injury where they injured their knee and then maybe the next day or the day after, then it starts to swell. Usually with like a grade 3 ACL tear or rupture, it's going to swell pretty instantly, and you know they're not going to be able to put a lot of weight on it either because there's no stability there. If you suspected an ACL tear or an ACL rupture, what kind of test would you order? All right, perfect. And again, you know, when you're more mild to moderate, you know, ACL, PCL type of injuries, conservative treatment's going to be the best, you know, for that. You're going to want to reduce the inflammation, and that's where, you know, that rest, ice, compression, elevation come into play. Your non-steroidal anti-inflammatories come into play. E-stim too, especially your interferential currents, are going to help to, you can mitigate or try to pump some of that fluid out of there and control some of that pain. There's also bracing that can be done. Remember we talked about either your neoprene braces, sometimes with the hinges, sometimes without the hinges, or even that kinesio tape or that spider tape. There's some different protocols to just add stability to the knee while it starts to heal. Because the knee is a weight-bearing joint, because circulation is not decreased, but it's a little bit harder because blood's going down through the arteries and then coming back up through the veins, and sometimes that flow is a little bit slower because of gravity. Knee injuries can take some time to heal. They do have poor blood supply to the knee itself, especially the interior compartment of the knee. So it can take a little bit longer to heal. It can take weeks, if not longer. You know, not only for the swelling to come down, but for the pain to come down. You know, and then once the swelling comes down, you feel the joints becoming more stable. That's where some exercises to strengthen the knee girdle muscles, you know, your rectus femoris, your hamstrings, those types of things, to just try to strengthen that area. Unfortunately, if there's a complete rupture, they're going to have to either reattach that ACL or PCL back to the bone. Sometimes they'll use cadaver ligament to do that. Sometimes they'll use the patient's own ligament to do that. It all just depends on the severity. If it unraveled and then tore, I would say then they were going to have to use a cadaver ligament or an artificial ligament at that point. If it just pulled off the insertion point off the tibial condyle, then they can usually just reattach their own, you know, ACL or PCL down there.
With the immediate swelling, do you see that in both ACL and PCL?
Yes.
Okay.
But just ACL are just more common. And
Okay.
again, because usually they're getting hit head on that way, so that's why that happens.
Okay.
You guys want to try that one? Because we can also, well, let's do this one too. Valgus varus stress test of the knee. What are we looking for? What structures are we testing?
MCL, LCL.
Uh-huh. Which is going to be your more common injury, MCL or LCL? What is it called when it's the meniscus, the MCL, and the ACL?
Donahue.
The terrible triad of O'Donoghue. So with that test, you're going to, if you wanted to evaluate the medial collateral ligament, you're going to support the lower leg with one hand. With the other hand, if the patient has a small knee like she does, you can actually palpate that joint line, and you're going to use, you know, a lateral to medial application. And you're going to see if there's any bowing of that knee joint. Usually there should be no bowing. There should be no instability. You shouldn't feel that joint moving like this. You know, it should be pretty stable. It should be pretty locked. And then you would then go to evaluate the other side, you know, doing the same thing. If you can, put your thumb line in there. And again, now you're going medial to lateral. Again, observing the same thing. Is there any give? Is there any joint play? Is there any clicking? You know, sometimes when it's pretty significant, you know, you can get the knee to, if there's a more moderate to severe type of an injury,